Cervical intraepithelial neoplasia, or CIN, begins quietly. Abnormal cells emerge on the surface of the cervix, dividing rapidly and threatening to mutate into invasive cervical cancer if left unchecked. To stop that progression, the mechanical standard of care relies on physical intervention. Surgeons employ conization, loop excision, or cryotherapy, processes designed to cut or freeze away the diseased tissue in a sterile operating environment. While these methods effectively remove the abnormal cells, they leave a permanent physical consequence. The cervix undergoes structural alteration and significant scarring. For a patient in her reproductive years, that damage introduces long-term clinical risks. A scarred or shortened cervix is associated with higher rates of cervical stenosis, structural incompetence, and premature labor. This creates a conflict between two clinical objectives: the immediate eradication of a localized disease and the long-term preservation of an organ's structural integrity. Photodynamic therapy offers a different approach. Rather than relying on a physical blade, it uses light-activated biochemistry to target diseased cells while leaving the surrounding healthy tissue intact. The protocol begins with an intravenous injection of a dormant photosensitizing agent. Over 48 hours, this compound circulates and accumulates in the fast-growing precancerous cells. By the end of this waiting period, the patient is biologically primed. The tumor site has absorbed the agent, effectively marking itself as a target waiting for a specific trigger. This clinical photograph demonstrates how physicians initiate that trigger. Using a specialized diode laser, they map 5 overlapping 1 centimeter geometric zones directly onto the cervical tissue and expose the area to 630 nanometer red light. That light acts as a molecular switch. As the dormant photosensitizer absorbs the energy, it transitions into an energized, rapidly vibrating state. The photosensitizer immediately transfers that energy to ground-state oxygen within the cell, which converts it into a highly reactive state known as singlet oxygen, or a reactive oxygen species. The precision of this reaction is determined by physics. Singlet oxygen has a microscopic diffusion radius of less than 20 nanometers, meaning its destructive effects are restricted to the immediate vicinity of the activated molecule. Within that restricted radius, the tumor cell collapses from within due to intense oxidative stress. The healthy cells sitting just nanometers away remain unaffected, preserving the architecture of the cervix. This localized destruction serves a dual purpose. As the tumor cells die, they release chemical signals that alert the rest of the patient's body to the presence of the disease. The collapsing cells release specific biomarkers, including ATP and calreticulin, which function as find me and eat me signals for the immune system. These signals recruit immature dendritic cells to the site. These cells consume the tumor antigens and mature, training the patient's T cells to recognize and attack the specific cancer throughout the body. Modern protocols now amplify this natural response. By priming the patient with vitamin D before treatment, clinicians can enhance the overall immune cascade. Vitamin D priming works by reducing the population of exhausted T cells while increasing the recruitment of active cytotoxic T cells to the tumor site. What begins as a localized application of light in the cervix results in a systemic immune response, training the body to defend itself against future recurrence. Real-world outcomes from Dankook University Hospital quantify this approach. This data table shows patients diagnosed with high-grade precancerous lesions. Their average age was 31, a demographic at a critical reproductive stage seeking an alternative to traditional surgery. The trial results demonstrated the therapy's reliability. In the group with precancerous lesions, the therapy achieved a complete remission rate of 95%, placing its success on par with standard surgical methods. However, unlike those surgical methods, this outcome was achieved without any measurable loss of cervical tissue or structural integrity. The clinical evidence indicates that biochemical precision can match the efficacy of a scalpel while avoiding the collateral damage associated with physical excision. The long-term viability of this preservation is seen in the follow-up data. Patients from the trial successfully carried and delivered healthy infants at 21 and 50 months after their treatment. Because the structure of the cervix remained intact, these patients experienced none of the surgical complications that often lead to preterm labor. This represents a shift in the management of cervical neoplasia, moving away from physical excision in favor of molecularly targeted light and reactive oxygen.
Best of all, treated patients completely maintained their fertility, delivering healthy babies with zero PDT-related complications.
So if a scalpel of photons can safely purge precancer, what diseases will light illuminate next?